Examples of drug-mediated type 1 to 4 hypersensitivity reactions. Type 1 mediated by IgE antibodies and mast cell degranulation. Acute anaphylaxis. Penicillins, chemotherapy, monoclonal antibodies, neuromuscular blocking drugs. Type 2 mediated by IgM and IgG antibodies. Hemolytic anemia, latency less than 7 days. Methyl dopa, penicillins, cephalosporins, NSAIDs, quinidine, quinine. Neutropenia or agranulocytosis, latency days to weeks. Antiarrhythmics, antibiotics, NSAIDs, antimalarials, antithyroid drugs, clozapine, ticlodipine. Thrombocytopenia, latency 1 to 2 weeks. Carbamazepine, heparin, penicillins, cephalosporins, NSAIDs, quinidine, quinine, thiazide, diuretics. Type 3 mediated by immune complex deposition. Glomerulonephritis, serum sickness, vasculitis, penicillins, cephalosporins, sulfonamides. Type 4 mediated by T cells. Skin eruptions including maculopapular rash, lichenoid or pemphigoid like reaction, drug rash with eosinophilia and systemic symptoms, DRESS, Stevens Johnson syndrome, SJS, toxic epidermal necrolysis or TEN, carbamazepine, abacavir, trimethoprim, dapsone, drug-induced lupus, allopurinol, thiazide, diuretics, hydrolazine. Type 1 is often known as immediate hypersensitivity, while types 2 to 4 are known as delayed hypersensitivity. See also boxes to 27.34 and 27.35. How to take a drug history. Information from the patient or carer. Use language that patient will understand. Example, medicines rather than drugs, which may be mistaken for drugs of abuse, while gathering the following information. Current prescribed drugs, including formulations, example, modified release tablets, doses, routes of administration, frequency and timing, duration of treatment. Other medications that are often forgotten, example, contraceptives, over the counter drugs, herbal remedies, vitamins, etc. Drugs that have been taken in the recent past and reasons for stopping them. Previous drug hypersensitivity reactions, their nature and time course, example, rash and anaphylaxis. Previous ADRs, their nature and time course, example, ankle edema with amlodipine. Adherence to therapy, example, are you taking your medication regularly? Information from GP medical records and or pharmacist. Up to date list of medications, previous ADRs, last order dates for each medication. Inspection of medicines, drugs and their containers, example, blister packs, bottles, vials, should be inspected for name, doses, and the number of doses forms taken since dispensed. ADR is adverse drug reaction. Risk factors for adverse drug reactions. Patient factors, advanced age, example, low physiological reserve, gender, ACE inhibitor induced cough in women, polypharmacy, drug interactions, genetic predisposition, see box 2.5, hypersensitivity or allergy, example, beta lactam antibiotics, diseases altering pharmacokinetics, example, hepatic or renal impairment, or pharmacodynamic responses, example, bladder instability, adherence problem, example, cognitive impairment. Drug factors, steep dose response curve, example, insulin, low therapeutic index, example, digoxin, cytotoxic drugs, prescriber factors, inadequate understanding of the principles of clinical pharmacology, inadequate knowledge of the patient, inadequate knowledge of the prescribed drug, inadequate instructions and warnings provided to patients, inadequate monitoring arrangement plans. ACE, angiotensin converting enzyme. From the previous page, can be misinterpreted by patients, but widely accepted meanings include very common 10% or more, common 1% to 10%, uncommon 0.1 to 1%, rare 0.01% to 0.1%, and very rare 0.01% or less. Classifications of ADRs. ADRs have traditionally been classified into two major groups. Type A, augmented ADRs. These are predictable from the known pharmacodynamic effects of the drug and are dose dependent. Common, detected early in drug development and usually mild. Examples include constipation caused by opioids, hypotension caused by antihypertensives, and dehydration caused by diuretics. Type B or bizarre ADRs. These are not predictable, are not obviously dose dependent in the therapeutic range, are rare, remaining undiscovered until the drug is marketed, and often severe. Patients who experience type B reactions are generally hypersusceptible because of unpredictable immunological or genetic factors. Example, anaphylaxis caused by penicillin, peripheral neuropathy caused by isoniazid in poor acetylators. This simple classification has shortcomings, and a more detailed classification based on dose, see figure 2.2. Timing and susceptibility DOTS is now used by those analyzing ADRs in greater depth, box 2.10. The AB classification can be extended as a reminder of some other types of ADR. Type C, chronic or continuous ADRs. These occur only after prolonged continuous exposure to a drug. Examples include osteoporosis caused by glucocorticoids, retinopathy caused by hydroxychloroquine, and tardive dyskinesia caused by phenothiazines. Type D or delayed ADRs. These are delayed until long after drug exposure, making diagnosis difficult. Examples include malignancies that may emerge after immunosuppressive treatment post-transplantation. Example, azathioprine, tacrolimus, and vaginal cancer occurring many years after exposure to diethyl stilboestrol. Type E, end of treatment ADRs. These occur after abrupt drug withdrawal. Page 21.